for ADS, yes.
Senior rheumatologists of the country, colleagues and friends. At the outset, I thank the organizers, especially Dr. Chandrasekhara and Dr. Dharmananda, for inviting me to discuss on the changing trends in the management of rheumatoid arthritis. As you are aware, rheumatoid arthritis is the commonest chronic inflammatory arthritis that is prevalent in our country and all over the world. And it is second only to osteoarthritis among the chronic joint diseases. And various epidemiological studies have shown that around 2.5 million Indians are suffering from this disease. Like the old story of the blind people understanding the elephant, our knowledge about rheumatoid arthritis widely varies. Whether you are a physician or a general practitioner or a rheumatologist or an immunologist, we understand and treat rheumatoid arthritis in our own way. But there is a consensus that the etiology is unknown, the clinical course and the modern therapy is now directed against these aspects of rheumatoid disease. If you look at the treatment of rheumatoid disease for the last century, our aim was to relieve the pain, reduce the inflammation, improve the functions, control the disease activity, and if possible, facilitate healing. But from this objective, we have moved towards a sustained and prolonged disease remission, if not cure. That is our target of therapy in rheumatoid disease, a sustained and prolonged disease remission, if possible, cure also. Conventionally, we had three major groups of drugs: the non-steroidal anti-inflammatory agents, the disease-modifying anti-rheumatic drugs, and the corticosteroids. As Professor Handa has already mentioned, the NSAIDs are the foundation of drug therapy in most of the inflammatory diseases. They act by inhibiting the cyclooxygenase enzyme, and we had very many chemical classes of drugs, and now we know how to choose them. As Dr. Handa has already told most of these points, I am just skipping this. The second, and we have very many side effects with NSAIDs. The second group of drugs were the disease-modifying drugs. They decrease the inflammatory synovitis, arrest or retard the progression of the joint damage. And we have an array of drugs: chloroquine or hydroxychloroquine, sulfasalazine, methotrexate, leflunomide. Previously we had gold, penicillamine, azathioprine, and so many drugs. But the major question the rheumatologist and the physician and the treating doctor is facing: which disease modifying drug one should start? Whether you should start with hydroxychloroquine, sulfasalazine, methotrexate, or a combination. The previous concept was to use very minimum drugs, prescribe minimum effective dose, start with the least toxic drug, and gradually and very reluctantly change to more toxic drugs. And physicians all over the world was very religiously following these instructions. But when we look back, the clinical outcome of rheumatoid arthritis with this strategy was quite unsatisfactory. It is also found that early aggressive treatment with with the disease modifying drugs has got a much better functional outcome in 5 years' time. If you look at the course of rheumatoid arthritis, from the onset to the first 3 months, you can call it as a very early rheumatoid arthritis. From 3 months to 2 years, we have an early established rheumatoid. After 2 years, either it become an established stable rheumatoid or become a resistant rheumatoid. And if you treat at this stage with a window of opportunity like or myocardial infarction, there is a window of opportunity at the disease onset, because there is significant radiological damage around 2 years of onset of disease. So the present therapy is mainly to start disease modifying drugs in early and established array. That is, from the onset of disease, just within 3 months, we have to start the DMRDs. And we have mainly this major group of drugs: hydroxychloroquine, sulfasalazine, methotrexate, and leflunomide. And as again Professor Handa rightly mentioned, methotrexate is first among equals and the best and the gold standard treatment. we usually give weekly dose, usually up to 15 milligram per week with folic acid supplementation. Another very useful and powerful drug is leflunomide. Usually we start with 100 milligram for 3 days, followed by 20 milligram and a maintenance dose of 10 milligram. Some people used to skip the initial loading dose. And recently we have also done a trial about a weekly dose of leflunomide, just giving 100 milligram daily for 3 days, followed by 100 milligram weekly. Because this has got a very long half-life, you may be able to control the disease with 100 milligram weekly leflunomide rather than giving 10 or 20 milligram daily. If one of the disease modifying drug alone is not sufficient, you can combine 2 or even 3 disease modifying drugs. We have methotrexate with hydroxychloroquine, sulfasalazine with hydroxychloroquine, or a triple combination of sulfasalazine, methotrexate and hydroxychloroquine, or a combination of leflunomide with methotrexate. So the current paradigm is to hit early, hit hard, and continue hitting with one or more disease modifying drug. So if you compare the disease modifying drug with the NSAID, it is like the old story of the hare and the tortoise. The slow acting DMRDs are the eventual winners as far as the control of disease activity is concerned. The third major group is corticosteroids. This is Philip Showalter Hench, who introduced corticosteroids in human ailments. And the first disease for which he introduced steroid was for rheumatoid arthritis. The initial results were so encouraging that he got the Nobel Prize in the very next year. But within a couple of years, the various side effects of high-dose corticosteroid Hench was using became evident, and people were afraid to touch corticosteroids. Today, probably corticosteroids occupies an intermediate place between the initial euphoria that greeted its introduction and the widespread criticism that followed due to the side effects. The major indications of corticosteroids in rheumatoid arthritis today are bridge therapy. When there is systemic involvement, you can try intra-articular injection. In pregnancy, and when there is a severe disease flare, you can give as a short rescue course. These are patients with rheumatoid vasculitis, nephrotic syndrome, or rheumatoid lung, where you may have to give a high-dose systemic steroid. Patient with rheumatoid arthritis and mononeuritis multiplex. But this is the other part of the story. This patient with juvenile rheumatoid arthritis was prescribed 5 milligram prednisolone by a local general practitioner along with chloroquine, but she found that the prednisolone is much more useful. Slowly she escalated the dose, stopped going to the doctor, and after 10 years you can see the deformities are already there. She has Cushingoid features, stunted growth, and bilateral avascular necrosis of the hip. It is said that steroids can make a dying patient to get up and walk towards his or her own graveyard. So one should be very careful when we are using steroids. But recently we have found that there are many new roles for this old front. A study in New England Journal about 18 years back says that steroids can delay the radiographic progression and also has got a disease modifying action. And a low-dose corticosteroid on up to 7.5 milligram prednisolone for a period of 1 year is found to be beneficial. But on a long-term use, it has got significant bone loss, glucose intolerance, and dyslipidemia. So it is better to stop steroids after a period of maximum 1 year. There are newer steroids that are coming. One is deflazacort with lower risk of bone loss, glucose intolerance, Cushing syndrome, and growth suppression in children. More expensive, but we can still try them in patients with these problems. People start using even lower doses, lower weekly doses of disease modifying drugs like 4 to 8 milligram medial prednisolone once a week. So steroids are also given as once a week. We are progressing from weekly methotrexate, weekly leflunomide, weekly steroids, and weekly folic acid. Probably we may be looking for a weekend therapy in rheumatoid arthritis. So we were standing now in this juncture. The NSAIDs produce an initial magic with great symptomatic relief, but they are eventually become a menace due to the long-term side effects. Steroids are a real blessing in life-threatening situations, but ultimately become a curse in our country because of the tumor necrosis factor, interleukin, interferon, growth factors and others. In rheumatoid arthritis, there is an imbalance between the cytokines. There is an increase in the pro-inflammatory cytokines, especially the interleukin and the tumor necrosis factor alpha. And these cytokines are responsible for the pannus formation as well as the persistent inflammation of the synovium. And if you can block them, you may be able to suppress the inflammation quite effectively and quite early to prevent the joint damage. And we have many anti-TNF drugs available. One group is the monoclonal antibodies, infliximab and adalimumab. There are soluble TNF receptors. Both of them wipe away the TNF from the circulation. This is etanercept, which is a soluble human fusion protein. Infliximab, which is a chimeric monoclonal antibody. Adalimumab is a humanized monoclonal antibody, like our old animal, partly animal insulin and newer human insulin. We have a chimeric as well as human monoclonal antibodies, and monoclonal antibodies against interleukin are also available, like anakinra. So etanercept is a soluble TNF receptor fusion protein which can be given as 25 milligrams subcutaneously twice weekly or 50 milligram weekly. Infliximab can be given as IV infusion, usually 3 to 5 milligram at 4 to 6 weeks interval. Adalimumab has not come to India so far. So just showing a video clipping how this acts. You can see that these trilobed structures are the TNF that is coming into the circulation. When it attaches to that receptor, it produces lot of inflammatory problems, produce lot of cell inflammation, release lot of cytokines, and then these TNF can be blocked effectively by using designer molecules. We may be able to prevent inflammation in a much better way. Based on this, there are a lot of molecules that is developed. Some of them I have already mentioned, many are in the pipeline. You can see this is etanercept, it's a soluble TNF receptor. What it does is that it joins with the TNF in the circulation so that the receptors are already blocked. You can see that the TNF get attaches to the etanercept molecule. As a result, the receptor sites are blocked. So when it is going to the cell, to the target cell, the receptor sites are already blocked, so the TNF cannot get attached to the cell surface. You can see that the etanercept the receptor complex is coming to the cell, but it cannot attach to the cell surface and it is going back. So basically most of these drugs are wiping away the TNF that is coming to the circulation. The other one is interleukin 1 receptor antagonist anakinra that is acting on another cytokine called interleukin 1. And the doses I have already mentioned. The indications are not only rheumatoid. Infliximab is approved for Crohn's disease and seronegative spondyloarthropathy. Etanercept is approved for rheumatoid, juvenile idiopathic arthritis, psoriatic arthritis and ankylosing spondylitis. Most of the patients who are using biologicals have a born again feeling of enhanced well-being. This is probably due to the prompt CNS effect of TNF inhibition. And I have only very limited experience. I had a few patients. This is my first patient way back in 2003. I have to give infliximab in this person. He was having severe rheumatoid arthritis, not responding to hydroxychloroquine, and was taking around 30 milligram prednisolone. He was an alcoholic, a central government employee who can reimburse. The problem was whenever I start in leflunomide, methotrexate and sulfasalazine, his enzyme level goes up very fast. Usually the SGPT touches 400, 500 level, and I have to stop each drug. And with hydroxychloroquine, he was not having much effect. At that time, 3 infusions of infliximab was given. He was all right. He was continued with hydroxychloroquine, but he came back after 3 years with another flare-up. And I have to give another 3 doses. So this may be produced. This is another patient who was a computer engineer, who has already taken a methotrexate and leflunomide combination, and he was working in Gulf. The rheumatologists there advised biologicals, but he opted for Ayurvedic treatment, came to Kottakkal, which is very close to Calicut, and after 2 months therapy he was almost bedridden, and one of his relative who was a doctor brought the patient to us, and we gave infliximab, and he had a wonderful relief of symptoms, and he was able to go back. Even though these drugs are expensive, they may be useful in affordable and really needy patients. Now, the major problem with anti-TNF agents in India, one is the cost, second is all of them are parenteral drugs, you have to give us injections, and there is a high incidence of tuberculosis. This is the largest study from Dr. Narayanan and his group from the Army Hospital. They had a 13% incidence of tuberculosis. But it is worth knowing these drugs because the lay press give lot of hype about these drugs. So somebody may be asking you, even your patient may be coming to you and asking you whether I should take this. Always tell them about the price. If they can afford, it is a good choice. The second target was the beta cells, the B cells in rheumatoid arthritis, the B lymphocytes. They produce rheumatoid factor. They also helps in the antigen presentation for T cell activation, and also produce a whole lot of cytokines. And there are monoclonal antibodies that are developed against the B cell, which is known as rituximab, which selectively target the CD20 positive cells. And you can give 2 injections, 1 gram at a interval of 15 days apart. At least 1 year remission is most likely in most of the patients. Many of them said to have longer remission. Now many newer drugs are also coming to India. One that has come last month was Actarit, which is not a very popular drug in US or UK, which is a phenylalkyl acid derivative, approved in Japan since 1994. It has got immunomodulatory properties. The dose is 100 milligram 8 hourly. It costs only 5 rupees per tablet, but we have to use them for a longer period to get its action. See whether these are really effective drugs. The second group are the co-stimulation blockers. As I said earlier, the T cell, the activation of the T cell is most important in the production of the immunoinflammation in rheumatoid arthritis. But that alone is not sufficient. Certain co-stimulation is also required. If you look at the T cells, they are activated by certain antigens that are processed. We are not very sure what type of antigen they are, but this antigen get attaches to the major histocompatibility complex of the antigen presenting cell. This is the antigen that is attached to the major histocompatibility complex and presented to the T cell. So this antigen presenting cell, the antigen and the T cell alone is not sufficient for the full activation of the T cell. There are certain co-stimulatory and inhibitory factors. This is one of the co-stimulatory pathway. There are several of them. Some of them are inhibitory, some of them are stimulatory. And this is one of the pathway which is well studied, the CD80-86 and the CD28 pathway. This is a stimulatory pathway, and once this pathway is stimulated, the T cell become very active. It liberates a lot of molecules and triggers inflammation. When the T cell is optimally activated, there are certain inhibitory pathways that are coming into play. This is the stimulatory pathway, and once it is fully stimulated, the inhibitory pathway is coming. This golden yellow one is the inhibitory pathway, the CTLA4. So this pathway is again well studied, and there are molecules that are developed which are structurally similar to that of the CTLA4. And this is what I was trying to tell. The antigen presenting cell, the major histocompatibility complex and the antigen, and get attaches to the T cell, but this alone is not sufficient. There should be some other stimulatory pathway. There are many pathways, some are stimulatory, some are inhibitory, but there are molecules that are developed which has got a structural similarity to this inhibitory pathway, that is CTLA4, and the drug is called abatacept, which is going to be launched in India this month. It is heard that the cost is around 22,000 rupees for 500 milligram. You have to take it monthly. Then IL-6 inhibitors are also coming, the interleukin-6 inhibitor. What is again coming to India is tocilizumab or Actemra. That is, you have to give 8 milligram per kilogram IV monthly. Many drugs are in the pipeline. I am not going to the details of each one of that. But what I want to impress upon you is that there is a paradigm shift in the management of rheumatoid arthritis. Probably in the next country update, many of the things I have already told might have been obsolete. As when the doctor was out for a walk, the secretary was downloading lot of information and telling that while you were out, the following paradigm shift has occurred. But if you look at the last 1 century of anti-rheumatic therapy, we had aspirin from 1900 onwards, we had gold, chloroquine, steroids and NSAIDs. But probably in the mid-80s, the methotrexate, which became very popular, has produced marked improvement in majority of our patients. Then we had DMRD combinations. In 1999, we had 3 drugs, leflunomide and the T2 TNF blockers that has come, anakinra and the prasorba column, which is an immunoabsorption column, not available in our country. Adalimumab came in 2003, 2005 abatacept, 2006 rituximab, and 2007 tocilizumab, and many are in the pipeline. The therapeutic pyramid of rheumatoid arthritis that was attracting the physicians and rheumatologists for many decades has undergone several changes. Previously we had the NSAIDs and the non-pharmacological measures that form the base of the pyramid, followed by the disease-modifying drugs, the steroids, the cytotoxic drugs, and the reconstructive surgery. But in the 2000, the yearly use of DMRDs also occupied the base of the pyramid, followed by the combination of DMRDs with low-dose steroids and the cytokine therapy and the co-stimulation blockers and the B-cell therapy also occupy an important place, at least towards the apex of the pyramid. There are many rheumatologists who still believe that the pyramid should be abandoned and the therapy should be individualized. As the famous rheumatologist McCarthy said long back in 90s, suppress the rheumatoid inflammation early and leave the pyramid to the Egyptians. But probably we may have to tilt the pyramid many a time or even invert it rather than totally abandoning the pyramid. This is my personal approach. The approaches widely varies. But if you looking back and looking ahead of the treatment of rheumatoid arthritis, you can see that this was considered as a florid crippling disease for many centuries. Then in the early 90s, we had the heydays of the NSAIDs. We had the advent of steroids and the ups and downs, and we know where to place this drug today. Then the upsurge of the disease-modifying drugs, the invention of the anti-cytokine agents, and today is the era of co-stimulation blockers and the B-cell targets. But the major problem we are facing in our country is this: these are prohibitively expensive. As the patient was already crippled, as going to the receptionist and asking, how much does it cost to see the doctor? That depends on how well you want to get. If you want to be better, many a time you have to use very expensive treatment. Probably once the patent period is over, or the Indian companies start manufacturing these biologicals, the price may come down, and many of our rheumatoid arthritis patients will be able to afford it. But many of this needy, affordable patient, this is a very good choice. And there are many Indians like that in our place. This is August Pierre Renoir, an impressionist artist who lived up to the early part of the 20th century. He was suffering from crippling rheumatoid arthritis. You can see his gross deformities on his hand. The only drug that was available at that time was a crude preparation of salicylic acid, which produced more gastritis than pain relief. But he modified his painting techniques, holding the brush in a peculiar fashion, and came out with enduring masterpieces that today occupies the art galleries of London, Paris, and Washington. This is one of his very famous painting, The Mother and the Child, which he painted with his crippled hand. That is now in the National Art Gallery of Washington, D.C. 100 years later, we have a great surgeon who was doing the first cardiac transplant. If you look closely, you can see the metacarpophalangeal joint that is swollen. He was also suffering from rheumatoid arthritis. But he was a proponent of aggressive treatment of rheumatoid disease with 2 or 3 disease-modifying drugs, and also one of the person who participated in the early trials of biological agents. And this is his picture when he came in 2001 to India for a campaign for BPL Mobile. You can see the metacarpophalangeal joint that is still swollen, but he was very active and died 6 months after the visit to India due to a myocardial infarction. Probably Dr. Handa may be saying that this is due to the lipid abnormalities. But what I was telling is that from the days of Renoir to the era of Christian Bernard, we have gone a long way in our understanding and treatment of rheumatoid disease. And with the current available therapy, a lot can be done to patients with rheumatoid arthritis, not only to decrease the pain and inflammation of the joint, but to suppress the disease activity early, to prevent the deformities and disabilities, and make them to have an active and relatively normal life. Let me stop with the words of Dr. Dorothy Eden, who herself was suffering from rheumatoid arthritis. Arthritis is a thorny word that seems to speak of pain. I myself, after 20 years of keeping rheumatoid arthritis at bay, call it a game of patience, of stoicism, of common sense, and above all, of optimism. I hope the newer drugs in our therapeutic armamentarium give us more confidence and optimism in treating these unfortunate patients with a miserable disease. Thank you for the patient hearing.
Thank you, Dr. Paul. That was really interesting lecture. In
early and aggressive treatment, but the dose of methotrexate is showed 5 to 15 milligram. I think anything less than 10 starting dose, at least the induction dose or initiation dose, is not very good, and the fear is patient may do not very well, and chances of flipping them into alternative medicine and steroid dependency are very high. I think several of articles in BSR in early 2003 and 2004, and some colleague from Mayo Clinic also said, people who are using only low dose methotrexate of 5 milligrams and all, disease is still grumbling, but the chances of methotrexate induced pneumonitis are very high. What do you say?
Yeah, in my practice, I start with 7.5 milligram, and I usually escalate up to 15 milligram orally. If I go above 15 milligram, I use injectables. This is my policy. And many of my patients after 15 milligram, I add a second drug. Many a time with powerful DMRDs like flunomide I used to add. Many of the patients who are already coming to me may be already taking hydroxychloroquine from a general practitioner or a physician. So what I am giving is around 15 milligram in majority of my patients, and the incidence of pneumonitis is extremely low. On a long-term use, some of the patients came to me with interstitial lung disease. It's again very difficult to differentiate whether it is due to the drug or due to the disease itself. Of course, in those patients I used to stop methotrexate, but many of the rheumatologists even believe that even in interstitial lung disease you can still continue with methotrexate. I am not that aggressive. I stop methotrexate, go with the other drugs.
I mean 5 should not be used.
Yeah, this is the dose that is given in most of the textbooks. Most of us start with 7.5 milligram.
The next question, please.
After your lecture, it seems that the treatment is so individualized, and all the combinations or protocols which you have put is
Rheumatoid also.
regarding the biologicals, not the others.
Yeah, biologicals are newer drugs. They have come to the market only last 9 years. 1999, the first biological was launched, and the only biologicals that were available were the anti-TNF drugs. And we have some experience with these drugs, most of the people in India. Then the B-cell based treatment, that is rituximab, came only recently. We start using it. Which biological first is a question of debate. Only time will prove it.